Morning, everybody. Good morning, everybody. I'm Mary Griskowitz from Point of Care Partners. Today, we're going to be talking about optimizing health IT and the impact for good. What we're going to do is we're going to really do a deep dive into CMS 0062, the prior authorization proposed rule for drugs. We're going to actually then take some time and go into all the proposals while we do that. Our goal for today is to really provide you with a roadmap for internal planning and give you some specifics and things for you to think about while you're looking at the rule and you're putting together your comments, which are due June 15th of 2026. The format for today is going to be half webinar and then half panel. We have several industry experts with us, and we're going to take a look at the rule in relation to and looking at connecting the dots into the final rule, the CMS 0057 rule that CMS finalized prior to the drug rule, really focusing on the medical component. We really will be looking for you guys in the chat for any comments that you may have. We have taken under consideration many of your questions that you've pre-submitted. Both our HL7 accelerator communities, as well as many of the industry trades that I'm sure you're involved with, are looking at the rule, they're processing it, and they're looking for deeper implementation specifications and things to comment on. So we really want you to engage with these groups in addition to working with point of care partners as you see needed, and we'll talk a little bit about that later. We will be providing a PDF of the slides, and this will be recorded. So anyone who has registered for this session will receive a copy of the recording. So please remember, put your questions in the chat. But remember, we also have an awful lot to go through, so we may not get back to you right away. But please put those in, and we will be looking at those. So if you have any new ones that we haven't covered, please put those in there, and then we'll be contacting you. So with that, we're going to get started, and we're going to go through the rule. Sorry, the slides are not advancing. What's that? I don't know if you could jump in. I'm going to pull it this way and see if I could get them to work. Okay. So we're looking at the who, what, and the when around this rule. What was the primary purpose of the rule? Looking at really advancing interoperability, making sure that interoperability is more than just looking at the medical component of it. It's also looking at the PA drugs, and many of you had commented in the original interoperability rule that drugs were left out. So the primary purpose is to really take a look at this new proposed rule. And again, just a reminder, the comments are due on the 15th. So the CMS interoperability prior authorization rule is really the focus, and it focuses on standards for drugs and what really needs to be addressed here. Together, what the rules accomplish is looking at the impact of the organizations, and particularly payers. And you can see I've listed here for you the Medicare Advantage organizations, the CHIP fee-for-service programs, Medicaid managed care plans, CHIP managed care entities, QHP issuers, federally facilitated exchanges, all must implement patient access, provider directory, provider access, payer-to-payer, prior authorization, application program interfaces, those APIs. And Medigap plans, just as a note, are not impacted by this proposed rule. Now, there are a couple of new added groups that we have to consider here that we haven't seen in the past. The small group market qualified health plans, the QHP issuers, or the federally facilitated small business health options, or the FS shops as we call them. And the group brings in the small group ACA plans into the same interoperability regime. as the Medicare Advantage and Medicaid for the first time ever. There are several operational deadlines. So when you're reading the rule and you're thinking about this, consider those operational deadlines. October 1st for main system build and operational readiness for electric drug PA and applied program interfaces, API updates, and January 1st, 2028 compliance for small group QHPs for small businesses through the federal facilitated small business health option programs. Now, I've been listening to some of the trade organizations as well, and I'm already starting to hear that these deadlines may be somewhat of a challenge. And some of the industry I've heard, for example, is already asking for some things like 18 months. The rule has several core mandates around interoperability improvements, in particular progress outlines, but there are requirements in the CMS 0057, and it closes the gap. We're really looking about electronic prior authorization PA and the liquidity of the data, right? And what those requirements are for all drugs, regardless of the benefit type. What we're looking at from a scope perspective is really getting to ensure that everyone is included in this. CMS has acknowledged that there are existing laws and regulations around prior authorization for drugs that may apply to impacted payers, such as existing electronic requirements for core Medicare PA drugs as well. So just making sure everybody can see that. And in the final rule, CMS really looks at those requirements for the impacted payers to make sure that they maintain prior authorization in that timely manner, January 1st. So think of these deadlines. Make sure that this is something as we move forward that you can definitely move towards as you're working with your business partners as well. So as we go through the rule, please look at all the requirements. We really want to see and we want to hear from folks, as well as CMS specifically wants to hear comments around the 2020 CMS Interoperability Patient Access Final Rule in relation to this and the Interoperability Prior Authorization Final Rule from 2024. Looking at the suggested standards for drugs and what really needs to be addressed. Really, the rules put together all the payers that are impacted by this that I've already mentioned. And again, we want to make sure that everybody is looking at the requirements. If we can move forward, Melissa, thanks for helping with the slides. Appreciate that. In this rule, there are several key proposals. It's important for you when you're looking at commenting to look at all of the proposals. Really, if we look at what the rule does is it's extending interoperability, right? This is an interoperability rule. Again, data liquidity. The requirements for PA for non-drug items and services to include PA. It mandates certain HL7 fire implementation guides and IGs, and we'll go into that in a little bit. And it recommends several that should be used, and there are those standards that are also required. It's adopting the HL7 fire standards and implementation specifications for transactions related to the PA under Health Insurance Portability and Accountability Act. And we'll talk a little bit about that because that's pretty much a big shift for the industry overall that have been using certain standards for a long time. Impacted payers are required to report their application program interfaces, API endpoints, and related information for patient access, directories, payer-to-payer, prior authorization, CMS. So that's something that the plans really need to look at. How are they going to report? What are the requirements? And then there are changes around metrics and some challenges that we may have around the API usage. So expanding the reporting in the API discovery process is something that we have to look at. When you look at changes to PA metrics, you're moving from percentages to raw numeric counts for approvals, denials, and appeals. You have new API metrics. Payers have to report on usage if you look at those APIs. And then centralized API discovery pairs must report endpoints, right? So that's something that you have to think about, and look at your technical documentation, URLs to CMS, and create a centralized national directory around that. And the other thing is a reporting timeline. The reporting timeline starts in 2028 for the 2027 date. So that's something that you're going to have to look at as well. So please take a look at this as we move forward. Melissa, if we could go to the next slide. So why is this such a big pivot? Why is this such a big change? Really, when we think about this, they're trying to unify the medical, the clinical, and the pharmacy ecosystem. If you think about care, right? When we have care, we want it to be holistic care. So creating a single regulatory framework around prior authorization really will help the patients, right? So CMS is extending interoperability and prior authorization requirements that previously applied not only to drugs and items and services to now include all drugs requiring PA, regardless of whether they fall under the medical benefit or the pharmacy benefit. Now, historically, medical benefit drugs used FHIR-based workflows, while pharmacy benefit designs use NCPDP standards, creating two separate universes if we think about it. So think of a game of kind of telephone. Somebody's on one side with a message, and then there's somebody on the other side. CMS is now trying to bring them under one rule, one set of timelines, and one transparency framework instead of siloed transactions. Medical and pharmacy have to be coordinated, right? So if we use an API-based architecture, this is a new framework overall. The information will be shared, and expectations for automation, data completeness, and turnaround time will definitely improve. The shared operational rules really create a common understanding, like an operating rhythm, if you think about this, right? For PBMs, payers, providers, and pharmacies, reducing fragmentation that was caused with delays and inconsistent patient experiences. CMS is looking for uniform deadlines for drug PA decisions for drugs and aligned those across the ecosystem. And again, in some of the calls that I was listening to yesterday, they really want to hear comment. Does the alignment make sense? Is it too soon? Is this something that we can accomplish as an industry? If we look at those timelines, you have now for PA urgent requests for 24 hours and standard requests for 72 hours. This mirrors the medical PA rule, and it aims to reduce delays in medication access. Payers are going to be required to provide specific denial reasons for drug PA as well. So this is something that they're trying to look at standardizing across the system. So examples of this would be if you have Medicaid and CHIP managed care plans, and you need to expedite the drug PA decisions, that would be, from the 24 to 72 hours. Standard requests aligned with existing item service rules. If you're in an ACA market plans, standard requests are 72 hours, expedited requests are going to be 24 hours. So just look at that moving forward. By embedding the PA into the same interoperability framework, this is going to really drive things, right? It's going to hopefully drive that real-time discovery for information inside the electronic health records and the pharmacy systems. It's going to allow the automated clinical documentation retrieval, right? If you're looking at FHIR, CDR, CRD, and some of the requirements there for the medical drug benefit, right? And real-time pharmacy checks, NCPDP, real-time benefit, right? And for pharmacy benefit drugs as well. Providers and pharmacists and PBMs now operate on a shared data, right? They're looking at all that information, and there is still a lot of manual work that happens behind the scenes. So reducing the manual workarounds with the faxes and the phone calls, there's all of the efforts that we've seen CMS move to, right? to make sure that the patients get the information that they need and the providers are able to help them with that is key. Payer public reporting would hopefully improve across the ecosystem with accountability, enabling comparisons between medical benefits and pharmacy benefit PA performance, and a unified timeline gives PBMs, payers, EHR vendors, and pharmacy systems a shared, modernized roadmap. And that's really key as we go forward. So when you're thinking about this, look at the entire picture. Look at the new ecosystem of interoperability that they're trying to create. Next slide, Melissa. So looking at the standards, it's really important as you're looking at your strategic plan to look at there's the standards are put in place, right? So what we need to do is they've named several standards when we look at this. For prior authorization API, patient access, provider access, API, and payer-to-payer, that's really required from the CMS 0057. The named technical standards here are pharmacy benefit drugs, NCP/DP standard script, the formulary and benefit, the real-time prescription benefit, and then for the medical benefit, it's the HL7 Da Vinci coverage requirements discovery, the documentation templates and rules, and the prior authorization support. Recommended technical standards include member attribution, the ATR, the list, the IG, the clinical data exchange, right, the CDEX IG, and what that provides, and then recommended infrastructure standards as well, really looking at the FAST framework, right? The FAST National Directory for Healthcare Provider Services. Now, I heard on a call a couple of days ago that this was probably due 6 months ago. That it's great that there's going to be a provider directory, but we also need that payer directory as soon as yesterday. So FAST is looking at this. They've been working on this. And so we need to make sure that folks are really focused on looking at these standards and providing feedback. Scalable guidance in particular, CMS is encouraging the use of fast fire and scalable task force initiatives and making sure that the industry can really address these. So again, looking at this, beginning October 1st, 27, CMS is proposing requiring the impacted payer to support the EPA for drugs that require prior authorization. NCP/DP CMS proposes 2 separate substance standards for EPA and drug and HL7 standards. So please make sure that when you're looking at this, you're commenting appropriately on the medical benefit and on the pharmacy benefit as well. So make sure that you're looking at this and that the CPDP script and the scope of the NCP/DP script standards and fire for EPA of drugs as well. Moving forward, Melissa. So there are suggested required standards for CMS 0057 and CMS 0062. I think what's really important is that you look at the API features and what those API features have really outlined between both of the rules. It's really important that you look at the medical rule and that you look at the PA drug rule. The combination, the maturity, and the concept of this is really important from a takeaway for your technical and product teams, making sure that you're shifting on how CMS is treating implementation, guidelines, the IGs under CMS 0057, fire IGs that were recommended or suggested, and then looking at CMS 0062, right? Looking at this drug rule and what are you going to gain, right? Look at the standards. They're proposing to make these standards mandatory and ensure high fidelity exchange across the industry. You have to look at the table. look at the comparisons when you're walking through it. There is a shift for pharmacy, right? Note what's out of scope and the status in the 0057 column versus the inclusion of the NCPDP script, the formulary benefit, the real-time pharmacy benefit, right, in the 0062. This is a rule formally bringing the pharmacy workflow into the interoperability fold. Medical drugs bridge. While drugs were previously excluded in 0062, now there mandates the Da Vinci CRD, DTR, and PAS IDs specifically for drugs under the medical benefit. Standards, the access APIs for patient provider and payer to payer. APIs were moving from flexible recommended model to a strict mandate for Karen Blue Button, Da Vinci PDEX, and bulk data access. CMS knows that the same drug could fall into different categories for different impacted payers based upon their terms of coverage, but they don't think it would undermine the proposal's effectiveness because the impacted payers could indicate which method a provider should use to submit a particular prior authorization. So from transactions perspective, really take a look at this, look at the formulary benefit and standard structure and the real-time prescription benefit structure as well, and provide your comments. Next slide, Melissa. This is a huge shift for the industry. CMS is proposing to retire the legacy X12 and 278 in favor of the FHIR PA, and this is a very consequential technical change for the entire industry. It's something that we have not seen. We have never seen a CMS standard retired, right, at this capacity. And that's like a 30-year-old practice. So really take a look at this and look at the implications. They're really trying to eliminate fax machines, fax processing. Then they believe in the way of doing this is retiring the standard, moving away from the 278 X12, and making FHIR become the default national standard as we move forward. So again, please take a look at this, comment on this. This is going to be really important because FHIR really is going to enable things they believe moving forward. And looking at a data quality and trust, that's what this rule is about. Streamlining the workflow, going beyond compliance, and improving data reliability overall. So please take a look at this. And I have a couple of more comments really from our point of care partners perspective and some resources we want to share with you before we move into the panel. Melissa, next slide. So point of care partners offers a solution called the prior authorization navigator. What we do is we track the medical information by state laws as well as the pharmacy prior authorization laws. These maps are helpful to you, and these maps and all of the information that we have, we look and we put into that solution. That should be able to help you moving forward. It's something that you could learn more about, but if you look at these maps in particular, Melissa, if you move to the next map, the pharmacy e-prior authorization laws, we track this as well. Again, it's something that you can subscribe to and that we can help you with as we move forward. So please know that we have this information. We update it quarterly, and it could be available to you not only in the maps, but you can have an online portal that you can go into as the states continue to legislate on the topics of prior authorization, whether it be medical or pharmacy. Know that Point of Care Partners is tracking that information. We have the information, and we have a solution that could help you track it as well as your compliance team to make sure that your products and solutions are compliant as you move forward into your next strategic planning and to continue to be compliant. With that, we're going to get a perspective from Alex and Pooja. Alex?
Thanks so very much, Mary. I appreciate the opportunity to bring my perspective as the Da Vinci program manager into the mix of today's conversation, as I agree that we are definitely advancing on the intersection of clinical and administrative data, and interoperability is really grounding us in that capacity to have a shared set of data coming from electronic health records and being able to be exchanged with payer systems while creating greater transparency for patients. The Da Vinci Project has been actively engaged with our federal colleagues on the rulemaking and alignment with the technical underpinnings from the medical side of the house. We've been focused on advancing a FHIR-based solution for discovering coverage requirements associated with prior authorization, enabling clarity on the data needed to support a prior authorization request through a questionnaire mechanism that we refer to in shorthand as DTR for documentation, templates, or roles, and ultimately leading to the capacity to have that FHIR interchange produce a faster response to prior authorization through clinical systems, but also meeting the policy objectives of our federal colleagues in the 24, 72-hour type timeframes. The recommendations that you're now seeing advanced in 0062 significantly indicate the advancement of methodologies that our federal colleagues are taking and leveraging prior piloting and real-world production feedback related to these FHIR-based standards. The paradigm shift we're in right now is necessitating organizations in reflecting on their historical investments that are the technical underpinnings that they need to modernize, while also thinking about the changes in operational workflows and the complexities that that'll bring as we embrace this new modern technology paradigm shift, and further fostering speed of transactions, but also the visibility and the public metrics reporting aspects. A couple of things I really want to call out for folks. When we're talking about CRD under 0062, we are talking about the coverage requirements discovery specifically only to eligibility inquiries for prior auth, not the major 270, 271 workhorse that we have in today's marketplace, only for prior auth. We also want to be thinking about how attachments are for prior authorization are different than the attachments that have been rolled out for under 0053 final rule that are specific to claims attachments. And so attachments in FHIR-based solution invokes what's called clinical data exchange to support supplemental data for prior authorization. Also, there is a terminology aspect that I want to create some sensitivity around. The term of expired IGs as part of the federal version advancement process and policy is not the same terminology used within the HL7 standards community. So expired IGs in the federal policy will really track to this concept associated with the standards versions advancement process, or SVAP. And when an HL7 implementation guide is considered expired, that only means that it is no longer being maintained. It's still available for use. So let's make sure folks aren't confusing federal policy around the term expired with how HL7 may use it. I do think that we have some questions in the queue, but I'm going to wait for those to let Pooja round out the perspective from an NCPDP before we get into a Q&A panel.
Yeah, thanks, Alex. Good morning, everyone. Pooja Babur, Executive Vice President at NC for Strategy and Industry Alignment at NCPDP. So just a couple thoughts before we dive into the panel discussion. One thing to keep in mind is, these standards are not new, from the NCPDP side. The script standard has been around, for many, many years, and the EPA transactions have actually been around for almost a decade now. In fact, NCPDP script has been mandated, it's a HIPAA mandated standard. But what is happening now is the EPA transactions within the script standard have been optional. And now with this proposed rule, we're seeing that they're becoming mandatory. I think the other thing to be thinking about, though, is this is really now, as Alex mentioned and as Mary mentioned, we're starting to see this connection between federal partners. So HTI-4 came out that mandated now EHRs have to get certified for the EPA and the real-time prescription benefit standard. And now we're seeing this go into the CMS proposed rule on the payer side as well. So just kind of another from our perspective, from the NCPDP perspective, we've always said that it's so important for all the standards development organizations to be working together. You can see that again in this proposed rule. It's really about workflow, right? And so people are kind of questioning why have two different standards that are named. But if you take a step back and look at it from the provider side, it's really about figuring out what drug is covered for the patient. It doesn't matter if it's under the pharmacy or medical benefit. But on the back end now, this allows us to use the NCPDP standard to get that information to the PBM for the pharmacy benefit and then FHIR on the medical side. I think the other, just real briefly, the other signal we're seeing from CMS, especially from our side, is we're seeing that the three transactions coming together. So we talked about formulary and benefit. That allows the provider to quickly see what medications are covered for the patient under the pharmacy benefit. The real-time benefit check will tell you whether a prior auth is required, and then also how much it's going to cost them out of pocket. And then finally, with the EPA transaction, that will allow you to submit to do a prior auth. So I think it's, we're obviously very, very excited to see this proposed rule come out. We've been waiting for it for a long time, and I think this really signals how CMS, ONC, others are thinking, as Alex says, right, our federal partners, our federal colleagues, to move the industry forward to really solve this problem. So really excited about this, and I think we're going to get into the panel discussion now.
Thanks, Pooja. My name's Brian Dwyer. I'm the business strategy lead for Point of Care Partners. I've met many of you already. Allow me, we know most of the panelists from their kind of presentations, but let me introduce two more panelists, Kendra and Vanessa. Kendra?
Hi, good morning, everybody. Kendra Arbrest, a senior consultant with Point of Care Partners. I focus primarily in the payer and technology market segments.
Hi, I'm Vanessa Candelora. I'm part of our payer provider technology workspace, and I'm the PP&T lead for management and operations. I work a lot with our HL7 accelerators and the team that supports them.
Thank you. So let's start right with our first question, and that will be going to Pooja to start. What should stakeholders understand about the named standards in this proposed rule as they think about implementation and comment development?
Yeah, that's a great question. I touched a little bit already on this in kind of my intro. I think the big thing is, when you look across the industry, most of the EHRs have actually implemented the NCPDP standards because they are, they've been around and they've also been mandated. So formulary and benefit is, people are already doing that. That's the ability for the provider to just see what's covered at a high level. Real-time benefit is another one that a few years ago we had a proposed rule where CMS required real-time benefit tools for Medicare beneficiaries. And it wasn't a mandated standard, but essentially because we had the standard, most of the EHRs actually have coded for that, right? So they may not have done exactly to the standard, but it is available within the EHRs. And then again, for EPA, it's part of the script standard already. We at NCPDP have been holding stakeholder action groups to talk about how we can get more adoption. But I think, when you're thinking about the comments and how to implement this, I feel like, NCPDP standards have really been part of the EHR. Maybe they haven't been part of the certification system, but folks are already doing that. So as you're developing the comments, I would think about more, how is this all working together? So from a health plan perspective, when I think about, what's really happening, the provider doesn't necessarily know what's covered under the medical benefit. And we used to talk about this a lot when I was at Point of Care Partners, right? Like we want the provider to be able to see all of the medications covered, whether it's under the pharmacy benefit or the medical benefit. So to me, some of the most important comments, at least from our perspective, is how are we going to get that information upfront to the provider? And in the NCPDP standard, we have the ability to do that. So if you're a health plan, why not send everything that's covered under, in your eligibility files, in the formulary and benefit file to allow that, and then on the back end, be able to kind of do that separation of where the prior auth goes. So those are some of the things that are we're trying to tackle here at NCPDP, and I know our stakeholders are looking at as well.
Alex, do you have anything to add?
Yeah, from a medical side of the house, and also kind of addressing, I think, one of the questions that I'm seeing in the chat box, I can kind of weave these together. From the Da Vinci standards perspective, there's a very big shift in how prior authorization is being done. From a 278 historical perspective, you kind of send over a request with some information and waited for a response. And that could come in a variety of shapes and timeframes. From the paradigm shift that we've done within the Da Vinci project is to say, start with the big question of, is there even a prior authorization required? And to do that from clinical workflows at preferably the point of time of that patient provider interaction, so that you can create this chatty kind of conversation that first says, do I need to even go down this path? Then once you know that you do or do not need a prior authorization, you can, if it's not needed, then you can just handle the scheduling and ordering aspects. Otherwise, you can go into this process of understanding what are the documentation rules so you're better able to have your EHR extract that data for you, pre-populate the questionnaire with supplemental data that's going to be needed, and then send that information along with your prior authorization step. So the point is, we're not trying to get faster denials. We're trying to get faster answers that prior authorization is not, in fact, needed. And what we found was that there was well over 75% of prior authorizations could be handled upfront at the coverage requirements discovery. And then you really are then narrowing down that volume of interactions you need to have to get to a more quality or a faster response time on prior authorization. So I
That's a big
think
impact.
it is a big impact,
Yeah,
as well as thinking about what that means operationally from your organization, the kind of responses, the quality responses you're giving throughout those coverage requirements, replies, or all the way to prior authorization, so that they're much more specific and actionable on the other end by patients and their providers.
thanks, Alex. Um, so 0062, as we saw in the previous slides, expands the use of the APIs that are named in 0057. So Kendra, would you please talk about what you're seeing as far as where payers are with their compliance to 0057, and if you think that work will make this work for 6.2 easier, or will it still be a really heavy lift?
Yeah, I think, well, across the board, I think payers are mostly on track to be ready by the end of this year for 0057. And when I say that, I mean, the APIs will be, ready. I think the trick is in, what does ready mean? And how will ready, evolve from being compliant to actually being useful. And I think that there's a journey ahead of us and an evolution in interoperability, not unlike the evolution that we faced many, many years ago with electronic claims. Everything didn't work perfectly the day the first electronic claim flowed through the system. It took, 5 to 10 years before that was a fluid sort of environment. I think we're going to face the same thing with 0057. And, every one of those APIs has a slightly different nuance to it. How are payers going to encourage members to activate the payer-to-payer API? What are providers going to actually be able to do with data that they request through the provider access API. For prior auth, are the EHRs going to be aligned with the payer side of the house, and what is it going to take for the providers to sort of have the trust in the technology and the payer community on the other side that this is worth the investment of their time and energy to really adopt into their workflows. I think we have a many-year evolution on that front. I think as it relates to 0062, the sort of two touch points there primarily, including drugs now on the medical side of the house. Most payers that we've worked with from point of care partners perspective were aware that drugs were on the horizon. And many of them are already implementing drugs into their 057 compliance program because while they weren't required, they also were not prohibited. So whether they actually are going live with drugs when they're first go round, they've been planning for drugs. Not everybody, obviously, but most of our payer clients have been planning for drugs because they knew this was coming at some point in the future. I think the other piece around the shift from recommended implementation guides to required implementation guides is going to cause the industry to go through another sort of round of maturation in those guides. They're going to work for the first round, the sort of getting ready to go out of the gate, but then they're going to need to evolve and mature as the use of the APIs evolves and matures, such that they'll be, go from being just compliant to again being useful.
Thanks, Kendra.
Yeah.
So as we've discussed, while 0057 only included services and devices that were covered under the medical benefit, it doesn't mean there has not been work that's been done and it's being done to streamline prior authorization for drugs. There's technology providers have been offering SaaS solutions to streamline drug PA, and there have been and are multi-stakeholder initiatives at the state level that have been exploring and actually executing on how to work ahead of policy because drug prior auth still has so much friction. Vanessa, can you talk a little bit about the work that's already underway and whether it'll, how it aligns with this rule?
Absolutely, Brian. And my colleagues really just said it well. What I think is really important to recognize is that while CMS 0057 may have formally scoped medical benefit services, the industry did not stand still, right, on the drug prior auth side. And a lot of progress has been happening as, people expected this, as Kendra said, and Pooja, the standards have been out there for a long time with script and real-time pharmacy benefit. There's so many PBs and Ts in there at the end. But I think it's really important to recognize that. We've seen meaningful investment from tech vendors, from payers, and PBMs around electronic prior authorization, touchless PA workflows, automating prospective EPA right at the point of prescribing upstream in the workflow, as Alex pointed out on the medical side. And real-time benefit and coverage checks are really bringing that greater transparency, and we need to build on that initial foundation. I think there's an opportunity to really see this being pushed forward. And we at Point of Care Partners recently did some research here in Massachusetts with the Mass Health Data Consortium, MHDC, to explore pharmacy EPA alongside a lot of their active work in the state with the NEHAN FHIR platform that's supporting the prior authorization Da Vinci guides for not just prior auth for medical, but quality data exchange and several other of the CMS named APIs like payer to payer, provider access, patient access, and provider directory. And Massachusetts has really been a leader in this work, recognizing that while NCPDP and HL7 standards are widely implemented for the most part, again, still building, their real world use is highly variable. And so, as people are commenting on this and thinking about what, sets the floor of this regulation, I think it's important to recognize that, as we always see in healthcare transformation, it's not always the technology that's the holdup, but the process and the people factors. And so some of the biggest challenges that we've seen here with our research is things like inconsistent setups, workflows that don't really mesh well between partners, just not having a clear view of the status of the prior authorization. And that creates a lot of back and forth, a lot of siloed communications between prescribers, pharmacies, and payers. And it means that we see a lot of duplication in the same request without that transparency up front, which also causes a lot of unnecessary delays to patients and overall just really wasted effort, even though the standards are in place. So something to think about as you're really putting your boots on the ground and thinking through this. What's really encouraging is that all of this work does align directionally with CMS 0062, especially the emphasis on the structured data, the automation, reducing manual back and forth. But where alignment really needs to be tightened, as my colleagues kind of said, is when drugs blur between pharmacy and medical benefit. So, especially common in specialties like oncology, where you might have IV chemotherapy generally covered under the medical benefit, but the anti-nausea and pain meds are going to be filled at the pharmacy and under the pharmacy benefit. And so, thinking about the work of HL7 Codex prior authorization use case, I'm hoping they see a boost or likely to see a boost in participation, and we'll get some more boots on the ground progress there. So, just to summarize and bring it back, is I see this rule less as a reset and more as CMS and our federal colleagues and partners signaling that the work that's been happening in pockets now needs to scale, get normalized, and integrate across this broader ecosystem. So it's a good thing, and we can do this.
Thanks, Vanessa.
Yeah.
Pooja, do you have anything to add to that?
I do. I just kind of want to double down on a couple of the points Vanessa made because, again, our standards have been out there for a long time. We've been real time since the beginning, right? So this back and forth, it's not like we are able to hit the PBM adjudication system. But when we take a step back, it's really about how it's being shown to the provider. It's the workflow. We, again, at NCPDP are trying really hard to figure out how are we going to get that prospective workflow adopted? And I want to take just a second to talk about that because what happens is even though it's integrated in the EHR, doctor can see it, they can submit it. A lot of times, maybe the note's not closed out till the next day, right? So what happens is a prescription goes to the pharmacy. Pharmacist goes to try to fill it. They get the denial saying a PA is required. So sometimes they may try to kick it off themselves, right? By doing the easy button within their system to kick off the prior auth. The doctor finally closes out the note. They start the prior auth. So from an actual adoption and workflow standard, that's what's not working. And so, we have been trying, we held a stakeholder act back in November to say, where are those workflow pieces breaking down? And that's really what we're starting to focus now is the adoption of it. I do want to just address a comment. I think there's a comment in the questions of will we eventually move to FHIR for pharmacy? I will say, like, we are hearing from our federal partners that they don't want to do that. We've spent a lot of time, things are adopted within the EHR and the pharmacy side for NCPDP standards. We're moving a lot of our standards to APIs. But when we try to look at the FHIR resources on the pharmacy side, it's just not what we need in order to get an in-depth, being able to do a lot of what we need to do on the prior auth side, the price transparency, all of that. So there's a lot of collaboration between NCPDP and HL7, but completely moving it to FHIR, at least what we've spoken to with our federal partners, is that's not really in the books right now, and we need to figure out that way to work together. So,
Thanks, Pooja.
yeah.
So, Vanessa, how are you thinking about transparency in the context of this rule, particularly when it comes to coverage costs and benefit design?
Yeah, great question. So one of my hats is a patient cost transparency use case co-lead within DaVinci. But stepping back from that hat and looking broadly, right? For me, transparency is really about reducing uncertainty at the point decisions are being made for providers and for patients. So that means clarity around all those things, Brian, coverage, benefit determination, requirements like prior authorization, step therapy, and patient cost implications before a provider spends time and effort on administrative work like initiating a prior authorization pathway, right? Alex mentioned earlier how much time is saved and how, we're not just automating denials with this, right? Which was one of our questions. We're moving the information upstream to give a transparent, hey, is prior auth needed for this or not, using CRD or real-time pharmacy benefit. Right. And I think that or is something that hopefully will come up in our panel again. It was touched on earlier, but I think it's a really key piece to comments later on. But I'll come back to that in a minute. I do think that without the clarity up front, patients are going to keep showing up at the pharmacy and can't get their medication, or they're going to keep getting a surprise bill and going into medical debt after a service, even if with all the things we have. So I think there's been a lot of progress on the pharmacy side of things, being reinforced with some of the regulations that Pooja pointed out earlier with HTI-4, including real-time benefit check for EHR, certification for the Part D final rule from 2024 for Medicare, which requires Part D sponsors to implement the NCPDP formulary and benefit and real-time prescription benefits starting January 1, 2027. Where I think we've struggled a little bit is actually where transparency for cost on the medical side. So real time or even in advance of services shouldn't just be for drugs. It should be for everyone, for everything, right? And so how we do that. And that's kind of where the HL7 PCT work comes into play, enabling providers and payers to exchange information to provide advanced cost estimates for patients in a way that's standardized and scalable. But so I'm glad to see that the CMS 62 is really creating an opportunity to further building on the drug side for cost, real-time information back to the provider, so that that can be shared with the patient in the office, ideally, before they leave. But I think it's important that we don't assume that a single workflow can fit both use cases. So it's really thinking a little bit broader than compliance and giving providers and their patients a predictable, understandable path forward, regardless of their benefit type.
Thanks, Vanessa. We're coming up on time here. We could probably have another hour and discuss this, and maybe we will. But let me open this question up to the whole panel. What do you think is one consequential shift in this proposed rule that organizations may be underestimating? Alex, you want to start?
I do because
you
I,
looked eager.
well, I'm thinking about it's the human factor. It's the operational workflows. It's the thinking about the paradigm shift of how we interact earlier and often between payers and providers with transparency for patients, and really try to look at this from a data liquidity perspective. I think someone used that term earlier, and I think that's really important. And so I think we're underestimating what it means to change how our staff and organizational structures think about and respond to the data information needs to fulfill their business models is my item. And I don't want to take anything away from my esteemed colleagues. So I will defer to the next person who wants to chime in.
I'll go
Because
ahead.
I would just
Free
build
for all,
on.
Pooja.
Go ahead.
Oh, go ahead, Pooja.
I think we're underestimating breaking down the silos between pharmacy and medical. Like, I think that is a huge issue. We are just coming off our NCPDP annual conference, and we had an HHS panel, and that was clear, right? We have to break down those silos between the data and get the PBMs and the health plans, sharing the data, talking to each other. I mean, technically, health plans, they're hiring PBMs. There has to be a way to be able to start sharing more data back and forth. And I think that's going to be really important.
There
And
are
I think
silos
this,
in healthcare? I didn't know.
Imagine that.
it's shocker, but I think we need to think about how US core data for interoperability and the other expectations in policy are setting all of these pieces in play that we now as an industry need to start to weave together more effectively.
Kendra, you were going to say something.
Yeah, I'm just going to briefly mention, I think the underestimated complexity of aggregating, managing, and sort of curating really vast amounts of clinical data over time, which really hasn't been done, certainly by the payer community. They've had clinical data in sort of isolated operational silos. Now they're having to bring that data together and not only figure out how to use it themselves to get value from it, but also have it be of high enough quality and currency to share with others, sharing with patients, sharing with providers, sharing with other payers. And I think that is a large lift in the industry, that there aren't enough qualified people to meet the demand. And I think it's going to have a direct impact on sort of the value of sharing that information.
I do want to try to squeeze one more question in. I think it's an important one. How can attendees engage with the HL7 except DaVinci Fast and with NCPDP to help them inform their comments? Did you want to start with that, Pooja?
Yeah,
NCPDP?
so we have a task group. It's the Education and Legislation Task Group. You don't have to be a member to join task groups. So I can provide Melissa with information to send out. We are in the midst, 90 minutes a week meeting to try to pull together comments. We will also be providing our comments to working with Weedy to make sure we're kind of aligned. Come join our task group and hear what's happening with our comments.
Alex, you
From a Da Vinci perspective, we are having a member consensus-based process develop our response to 0062 with, of course, a focus around what's germane to Da Vinci. But we've also recently held a community roundtable, and that slides and the recordings are available on the Da Vinci Confluence space. So folks can take a look at that recording from the end of April. But then we're going to be coming back at the end of May and providing an update on where the membership has landed in the themes of our response. So at the May 27th, I believe, Community Roundtable, there'll be an update there, which will hopefully give folks some time to consider those remarks as they are preparing their own response. We're also participating in a weedy upcoming member policy advisory meeting, and we're also doing collaboration with our industry partners as they're looking for feedback and we're looking to hear their views. But I think it's important that folks know that you can roll up your sleeves and get involved in HL7 Da Vinci or NCPDP. It's a great place to participate to ensure that your stories and experiences are coming to bear through the standards development process, and that you also have an ability to influence the trajectory of those standards to reflect your business needs.
Thanks, Alex. So I think we're hitting up our time.